Thank you. I'd like to thank the organizers for inviting me and Dr. Nambiar and his group. And it's always hard to go after Dr. Levine, I mean Dr. Nathan, because he always gives such an elegant talk, and I love his slides. We were just talking, we wonder how you make everything move so well. You'll have to teach us. It's a secret. It's a trade secret. But actually, I'm glad I'm going after him this time because he made a couple things easier for me going forward. As we know that, excuse me, people who have PH along with IPF are at higher risk of death, and they usually need to be evaluated much sooner for lung transplantation. So our charge today is to talk about who should be referred for lung transplant and when. I can just tell you the answer now and then we can go. They need to be referred early. But let's talk about who. So I have no disclosures except I am an organ donor. I keep changing the first slide whenever I give some talk like this, and I never know how to exactly say it right, but lung transplant is a treatment strategy for appropriate patients with end-stage lung disease to improve survival and quality of life. And I think the big thing we need to know today, we need to know, going the wrong way, is appropriate patients. So whether it's IPF, PH, CF, a patient needs to be evaluated very thoroughly for lung transplantation before we know if it's the right thing for him or her. So the first lung transplant was actually in 1965, and that was done in University of Mississippi by Dr. James Hardy, and he's actually a prisoner who had a lung transplant for what's now a contraindication to lung transplant. He had a left upper lobe carcinoma, and they took off his whole lung and actually told him, if you go through this procedure, we may be able to get you out of jail earlier, which I think would not be helpful today. I don't think that would work in clinical trials. I think our IRB wouldn't like that. But they did get him out in 14 days, but he had died. He didn't die from an unfunctioning graft. His graft actually was working fine, and they did the biopsies, and it looked good on the explant. He died of renal failure. We know there's a lot of comorbidities after lung transplant, and those are things that you need to look at before transplant to make sure that these things don't hit you twice after transplant. Since that time, and really in the and I don't know what happened to my slides, I'm sorry, it's really dark down there, and I'm trying to, which one is this pointer? Let's see, nope, oops, wrong one. Could this be it? Nope, okay, sorry guys. Okay, I found it. This is time on the x-axis. This is a slide from the IHSLT slide. You're going to see a bunch of slides from the International Society of Heart Lung Transplant, and obviously it's international. This is international data. But what you have on the x-axis is time from the 1980s, 85, all the way up to 2016, and numbers of transplants being done. And you can see in the last 20 years, our numbers have gone up exponentially. Bilateral lung transplants in the purple much faster than the green. So over 4,500 patients were transplanted in the world last year, or a couple years ago. This is from 2016. We were very successful with numbers of transplant. We still are. However, our success is not as good when you look at our outcomes, because you can see this is, again, years on the x-axis and percent survival on the y. You can see in 3 different time eras that, and this is the most recent, that really our outcomes, our long-term survival isn't as good as other organs. So this is like about a 6.5 year, 50% survival. And when you compare that at other organ outcomes, obviously we're a little bit far behind. Why is that? What is wrong with all of our patients where their outcomes are not that great? Well, I think if you look at another slide from the IHSLT, percent deaths with actually years on the x-axis, you can see within the first year, really infection is one of the biggest reason for patients not doing well. But after 1 year, it's really chronic lung allograft dysfunction, which has the phenotype, remember, of BOS, bronchiolitis obliterans syndrome, or RAS, restrictive allograft syndrome. So really, the first year and after, really, CLAD takes over, and that's why we have worsening outcomes. When you split up the patients that are the cohort of patients who've been transplanted, you split them up by diagnoses. You can see that not all diagnoses do as well or as poor as each other. And so you can see, again, survival on the y-axis and years on the x. And this is cystic fibrosis, which they enjoy the best outcomes. PH has the next best if it's long-term outcomes. And you can see that IPF or IIP has a little bit less of a good long-term outcome, 5.5 years, 50% survival, and non-IPF ILD at about 6. So not at the top of the barrel, and we'll figure out that why in a minute. If you take it a different way, and you take out that 1 year if a patient survived to 1 year, so conditional on 1 year, the outcomes are a little bit better. And patients with IPF are about 7 years, and patients with ILD, non-IPF, are about 7.5, 8. But you can see that patients here who are CF and PH have about 10 to 11 years, so still a little bit less than the others. What about lung allocation? How do we get donors in this country? So the lung allocation score is what's been the way we allocate lungs since 2005. Prior to 2005, lung allocation was done on kind of a waiting time. So if you've been on the list 6 months, you get the lung before someone who's been on the list 3 months. Too many people were dying on the list, and the survival was much lower, so they went to acuity-based lung allocation score, and that's what the LAS score. It's based basically on a patient's blood type, their size, the LAS score, which we'll go over, and a little bit by region, not as much as before, but a little bit by region. And what it takes in this big calculation, what it takes into account is both the waitlist urgency as well as the transplant survival. And they split patients up into their diagnostic group: A, obstructive lung disease; B, pulmonary vascular disease; C, CF and non-CF bronchiectasis; and D, being restricted lung disease, so the ILDs and the IPF. So just looking at this is a slide of just a picture of what you do when you're listing a patient. So you put all of these factors into the computer, and it spits out a number. And the LAS score goes from 0 to 100. Obviously, 100 is the highest. 43 is about an average score. And you can see the things that are important in this score, most important, heavily weighted, are the lung diagnosis code, assisted ventilation and oxygenation, and the FVC. And so people with IPF with a very low FVC and on a lot of oxygen, they get a very high score. So they're benefited by this LAS score, which is good because they are the sickest patients. So since they are the sickest patients, we can see that they're going to have the highest score and probably be transplanted more than anybody. So this is another slide from the IHSLT database. Percent of transplants by major diagnoses and years. And you can see I put a dotted line at 2005, which is when the LAS score started. And you can see before that, COPD and alpha-1 were the highest amount of patients being transplanted. And, IPF was there, but not, incredibly high. Bless you. So what happened after the score was developed, you can see that IPF and ILD just grew significantly, and COPD has gone down because they can hang out a little bit longer on their scores are usually lower. So the sicker patients who are getting transplanted, IPF patients are patients who are the sickest. This is just a slide from the SRTR database, and it shows us the same thing, 2005, 2006. COPD is kind of going down. These are patients on the waiting list, and IPF patients are just taking on steam. And that shows you the same thing about patients who are actually being transplanted, just out exponentially increasing for IPF, and patients who are, everybody else is kind of about the same. So IPF really is our #1 percent of how patients get transplanted now. This is just months on a waiting list. So after the LAS score, they waited much, much less in terms of time of getting transplanted. What about transplant procedure type for IPF? Well, this is another slide from the IHSLT, and it really goes through COPD and IPF or restrictive lung disease. For CF and PH, 99% of patients are being transplanted for with bilateral lung transplants, so it's not here. But you can see, let's really take a look at the patients with IIP and ILD non-IIP, and you can see really back in the early 2000s, more patients were getting transplanted with single lung transplants, but really it's kind of the tables have almost turned. It's over 50%, but there's still a very big controversy. There's papers still looking at single versus bilateral, and each patient and each center has to look at that patient individually for the risks and the benefits. If we have time at the questions, we can talk more about that. So for IPF, probably about 60-40 bilateral to single. So really, here we are. We need to look at these patients. Should we refer the patient? When should we do it? And how do I do it? Well, this is a very good resource, and if you don't have it, I have my email at the end, and I can send it to you. And this is the third iteration of the IHSLT consensus statement on referral and listing for lung transplant. It's not just about IPF, but it has everything. And it's nice to have in your clinic. You can just turn to the page and look at each criteria for each disease. So this is a nice article, and it was from 2015, and it's probably almost time for another one, but it gives a good idea of timing and things like that. So in general, all patients, not just IPF patients, really in general, if a patient has a high risk, greater than 50% of dying within 2 years without a transplant, that's a good reason to transplant someone or refer them. If they have a high likelihood of at least living 90 days after the transplant, then that's another criteria. And then also not just the short-term 30 or 3-month survival, but do they have a good chance of living 5 years from the transplant? So if they have another disease that's not going to let them live, they'll probably may consider him not or her not a candidate. So that's in general. When you look at interstitial lung disease, and this, by the way, this paper has every single disease state, so it's really nice. They split everything up into timing of referral and timing of listing. So timing of referral, I yellowed out the only thing we need to talk about. Because in IPF, ILD IPF, as soon as you notice that the patient has interstitial lung disease, it's time to refer them. Why? This disease we've heard all day and we'll hear this weekend is all unpredictable. I had a patient that came in, he was on 2 liters, doing great, working fine. I said, you know what, I'm gonna see you in 3 months. I don't think it's ready, you're ready to be listed. He was the first time I ever saw him. I was gonna see him in 3 months. He came back 2 weeks later. He had a virus, he was transferred and put on Ecmo, and he didn't make it. So it's so unpredictable. These patients could go for 5 years and this could happen to them too. So seeing a lung transplant center, even if they say, hey, he's doing great, we'll follow him, that's fine. You know, the CF people have it right. I don't know if anyone's seen the new guidelines for referring patients for transplant, but they're under the impression, and right impression is, hey, let's get patients at least to visit, to feel comfortable, to know about what transplant is, even if it's just a discussion with the transplant people to say, no, I don't want this, or yes, I do. They appreciate the opportunity. Even if they say, I really wanted to meet you, but I don't want a transplant, I feel like we've done something for them. So besides that, there's definitely other criteria, but that is really the main criteria for IPF. If they have a histological, radiological sign or evidence, then it's time to at least have them visit. Time of listing is a little bit different, and we will go over that if we have time. So there's also absolute contraindication. Remember, this is from 2015. These are already changed. This is how these guidelines go. You have these indications, and then as we learn more and as we have more experience, we can make them relative contraindications and then not contraindications at all. So right now, some of these are still relevant and some of them are not, but I've just kind of bolded out some of the ones that are important. Recent history of malignancy, and usually it's about 5 years when they've been cancer-free and in remission after treatment. an untreatable dysfunction of other major organ system, unless they can get a dual transplant, if they have renal transplant, if they have a renal disorder that's not fixable, possibility of doing a a lung kidney, uncorrectable atherosclerotic disease, not amenable to revascularization, substance abuse or dependence, medical non-adherence, obviously, absence of social support, and severely limited uncorrectable functional status. Some of these are correctable and some of them are not, and that's where you have to go absolute to relative. I then put relative contraindications, and I kind of yellowed out the ones that I think are important for us in IPF. These patients are older, right? They get diagnosed in their late 50s, early 60s, so age in some centers is an issue for these patients. Most patients are being transplanted. Most centers are transplanting patients up to age 70, some to 73, 74. But back when this was written, most centers were doing 65. So basically, this is already defunct. Class 1 obesity, people are usually kept at a BMI of 30, but now patients are being transplanted at 33, 34, 35 sometimes in certain centers. Again, a relative contraindication. Extensive prior surgery, the only reason I put this is because a lot of patients still have biopsies, and so it's not a contraindication in anymore. But in some centers, extensive prior chest surgery would be. Remember, mechanical ventilation and Ecmo was relative contraindication, and now so many patients we'll see are being transplanted more off of Ecmo than off mechanical ventilation. And we'll talk a little bit about that one. Some of these other things are important, but I wanted to go to atherosclerotic disease because I think most people will be looking at mild atherosclerotic disease in the next 2 slides, and also why it's important in IPF. Other medical conditions should be optimally treated before transplantation. So let's talk about a few of those. Let's talk about Ecmo. Yeah, Ecmo has really exponentially increased in some patients prior to transplant. This is from 2013, and I'm sure it's going up. But I think what we have to remember about this is although the numbers of Ecmo may be going up as a bridge to transplant, when you look at this study, you can see that although a lot of them have risen over the last years, when you look at how many really are on no Ecmo and no mechanical ventilation, it's still 91% of patients, although there is an increase. Most patients are still being transplanted like a normal walking person, not on Ecmo. But it is now not a contraindication. Now I want to talk a little bit about comorbidities of IPF, and I'm not sure if you had a lot of the discussion today on that, but these are some of the comorbidities that actually affect the transplant team, and so it's a really important thing. I mean, we already talked with Dr. Nathan about PAH, or where's PH? PH down here, atherosclerosis we're going to talk about. We're going to talk a little bit about diastolic dysfunction, but all of these things may affect the patient afterwards. I don't see Gerd. Do we see Gerd? Gerd should be in there somewhere, but we'll talk about it even if it's not in there. So CAD and IPF, you know, I was looking in the literature, is CAD associated with IPF, or is it just a kind of just a consequential thing? Well, we know they share a lot of the same risk factors: age, older male, gender, smoking history. Many patients have smoked. OSA is an independent risk factor for CAD, and 58 to 86% of patients have ILD. In many studies have OSA. There's a lot of studies on IPF and CAD, and the retrospective studies go from like 10 to 30%, but there's a couple studies, including this one, that show the patients who are being evaluated for lung transplant with a left heart cath, that up to 70% of patients had CAD already, and 20 of them had a significant or obstructive CAD. Another analysis showed that even after they were diagnosed, that's when many patients develop CAD after the IPF diagnosis. I don't know if we have been talking this week about, weekend we'll be talking about the short telomere syndrome, which we know is important in IPF patients, but very, very important in transplant as well. We'll talk about that in a second. Also with CAD, and I didn't know this until I read this, is that it can also lead to the cellular senescence that can lead to the development of atherosclerosis. So there may be some real association in patients with CAD and ILD or IPF. We talked a lot about already pH, and Dr. Nathan did my job for me for most of it. But when you look at pH in IPF and ILD, most of the patients are going to have either group 3, number 1, or group 2 disease, diastolic dysfunction. Why do we care about that? Well, because any type of pH, whether it be PAH, group 1, 2, 3, 4, or 5, any type of pH is the patients are at risk for primary graft dysfunction 2 to 3 times post-transplant. And PGD3, there's 4, but 3 is associated with a longer stay, ICU stay, mortality, and bronchiolitis obliterans, or CLAD. So this is why any pH, whether it be group 2 or group 3, they have to be evaluated and hopefully treated so we can get them better. And I'm not talking about pre-transplant, I'm just saying this is going to happen post-transplant if it's not treated. So this is just a slide I think is really neat because it looks at a lot of patients that we see with IPF or ILD, right? A lot of our patients are connective tissue disease. These are a lot of the patients that we transplant. And a lot of them have some type of pH. And Dr. Nathan already talked a little bit about PVOD, but some of them can have some type of clotting disorder and have CTEPH. They may have group 3. They may or may not have group 1. If they have scleroderma, they could, you don't know if they have group 1 or group 3. They could have pulmonary veno-occlusive disease, as we were talking, and they could have some myocardial involvement. And what I mean about myocardial involvement, we'll talk about in a minute. Some of these disease states may directly affect the myocardium. So most patients are going to be group 3, right? We have a restrictive lung disease. They're going to probably be mostly group 3. And this is a nice graph that says, hey, they have group 3 pH from interstitial lung disease, but it really could be from any type of lung disease. And this is going to lead, because of all the decreased oxygenation, to increased pulmonary vascular resistance and to pH that can lead to right ventricular failure. And that's important because post-op or perioperative, these patients are difficult no matter why they have pH. They can be difficult in the ICU, taking care of them post-operatively. Well, what about group 2 disease? Well, we already talked about the right heart. How does the left heart fit into this? Well, if you have a decline in your right heart and you have an underfilling of your LV, you may have some ventricular dyssynchrony that may lead into bowing of that ventricle that septum into the left ventricle, impairing that left ventricular filling and causing some kind of diastolic or systolic dysfunction. So it's important, and this happens after transplant with IPF patients. They have issues perioperatively with this. So I think that's a very important issue. The other thing we talked about a little bit was connective tissue disease and sarcoid, which is in there as well, that they may have direct involvement with the heart. Okay, I did that twice. And this is just a slide showing that diastolic dysfunction, group 2 disease, which a lot of patients have in their 50s, 60s, 70s, can lead to PGD and to post-transplant decreased survival. So all important to try to fix that. And this is just a nice graph about patients who have HFpEF or diastolic dysfunction. Try to figure that out before, and maybe we can work on that so it's not so devastating after transplant. What about Gerd? It wasn't in the big circles, but obviously Gerd is super important for us as transplanters because we know that it may be symptomatic and asymptomatic. Most or many patients have it in IPF, thinking that microaspiration may be even taking a role in the disease state. And it is, in our world, after transplant, a absolute non-immune risk factor for chronic lung allograft dysfunction and decreased survival. So these patients go through a thorough workup for their esophagus, their stomach, their gastric emptying, pH probe, manometry, esophageal motility. We need to optimize the therapy, and that could mean the patient may need a wrap. So we could do that before transplant or sometimes after transplant. So super important comorbidity of IPF. Frailty. Frailty is big now and everything. I know it's the new buzzword, but frailty is very important for patients undergoing lung transplant because they can't get through it, they can't get through it. And these patients need to be in pulmonary rehab. They need to be working so that they can be strong enough to get through if need be, a 10-hour surgery if something goes wrong. So we know that sarcopenia, malnutrition, weakness, is all part of frailty, and the presence of unintentional weight loss, exhaustion, weakness, and low activity level makes it very difficult. We do, as most lung transplant centers do, frailty tests before they undergo lung transplant, and if they don't make it, they need to continue with their pulmonary rehab. This is just a nice study in pre-transplant patients that show if they underwent pulmonary rehab before transplant, number one, their outcomes were better, but also their length of stay and their ICU stay was improved if they did all their pulmonary rehab. So it's really important. And just for their quality of life, they love it once they go, and it's just hard to get things moving. So what about decisions about referral, selection, and listing? I think that's what we're talking about now. Referral is number one. We can't get to see the patient, they can't get to know us if they're not referred. So number one, the most important thing on this slide is refer them early, even if they're not what you think may be a candidate. They may be turned into a candidate. The timing of referral is really influenced by what you know of the patient, the natural history of the lung disease, which for us means nothing because it's such an unpredictable disease with every patient. The unique characteristics of the individual patients may deviate from normal history, which we know is every patient with IPF. And many patients have at least one episode of an acute exacerbation. And why is that important? Well, because this is a study that just came out last year which showed if you have a lot of exacerbations, you're not going to do as well post-transplant. So you want to get them transplanted and done before they can have too many. Timing is everything. Referral early. Variables to consider is we don't just put them on the list and they get transplanted. If you're in an area that doesn't do a lot of transplant, if they have a weird blood group that isn't common, or they have a lot of antibodies that we have to match, the patient may need to have something fixed up and changed before transplant, maybe lose weight, maybe do something, maybe they're too frail. You need all the time in the world to do this. So we want to get them listed so they have the time before they end up on Ecmo and may or may not make it. Remember, when you look at patients on Ecmo, the primary great patients on Ecmo are not the 65 IPF frail patients. They're younger. So we want to get these patients in before that happens. Early referral, like we just talked about, it helps you to do all the things we need to do to get someone in shape for a transplant. It's almost like running a marathon. So these are the things that we would do prior to listing. I just want to put all this because I don't like to do all the things. Anyways, so this is a transplant window, and I want to just talk you through it because here's the diagnosis, and I think making this part as short as possible. I mean, this should be together. This should be diagnosis referral. It shouldn't even be a space because of all the things we just talked about. We need this opportunity to talk to the patient to see. They have to get their heads around it. If we say, oh, we're visiting with you and we're going to start a lung transplant eval right now, it's not easy for them. They need time to digest it, talk to their family, come back and meet us, and meaning me, not the whole transplant community. But I think that is why make this as short as possible. If you're going to start nintedanib, if you're going to start pirfenidone, don't delay referral just because you're starting the meds. We're going to start the meds, we'll wait about a month, see if he gets better, and then refer. Just do it. Just do it at the same time. That's simultaneously. So you refer them, and then they're too well for listing, but not for referral. they're never too good to be referred. We're not going to just put them on the list if they're, we might say, hey, come back in 6 months or whenever your doctor says he needs to, but at least we'll meet them. Once you meet a patient, they're kind of in that circle. Get them in the family, you know, because, oh, I remember I saw you about 6 months ago. You never came back, but it's so much easier than if you get a patient that's coming from another hospital to try to get on Ecmo and get listed. So that is the thing where your centers are to really do that. And again, we talked about giving time to fix those problems, because at some point, there's some magic box here that they're in the green zone, but at some point, they may be too sick for transplant. Referral. Okay, so never too early to talk with the transplant team. And lungs are the focus, but there's so many things that are not even in our purview that we have to deal with to get the patient ready. So if you have any doubt, just call your lung transplanter and say, hey, what do you think of this? Most of the time, they're just going to say, you know, let's just see him, or I'll come see him if he's in the hospital. You know, that's what they want, is so that the patient gets the safest route to transplant. You don't want to do a transplant when they're super sick. You want to do it when they're sick. So I think that's it. I was just going to say that we all know that it's a very devastating disease and there's no cure. We hope there's a cure soon, but right now there's not. And out of all of the disease states, it probably is the one with the most unpredictable course, and we just don't know who's going to do worse at what point. So lung transplant continues to be the best therapy for these patients if they're appropriate. And again, it's imperative to get early referral. So thank you very much.